people here already. That's great. Lovely. Right. So first of all, just a couple of housekeeping things before we start. And that's obviously if everyone can keep yourselves muted for the first while whilst I do the presentation. And then what we'll do is we'll open up for Q&As and anyone can unmute themselves and jump on and or pop it in the chat box. Secondly, I am recording this. So if anyone doesn't feel comfortable about that being used in future, then I don't think we have cameras on anyway, unless perhaps in Q&A we do. Like I say, this is new to me. So, but anyone can reach out and let me know if they're okay about that. Yes, Sarah, I believe you will be able to receive the recording, but again, brand new to all of this. So I am hoping so. I'll make sure that you do. There's also going to be slides that you'll receive afterwards. So I'm going to show you the slides and talk them through and then send them all to you as well, guys. And last thing, I think that's everything for housekeeping. So I can now, I'll pop on and get started. So as I say, my name is Emily Kirkcaldy. I'm a speech and language therapist, and I've done that job for about 20 years now. And then for the last 4 or 5 years, I've been an orofacial myofunctional therapist, which sounds like a mouthful, and it is. And what that basically means is, well, actually, I'm going to tell you a bit more about that, so I'll wait for my presentation. I'm also a Buteyko breathing instructor. I got into those things from speech and language therapy because of issues that my own children were having. With their breathing, their sleep, and their teeth. And once I fell into this, I couldn't kind of unsee any of these things, and I was well and truly hooked on the impact that these things can have. So I'm going to share my screen with you now and share with you a presentation, hopefully. So this is going to take about 40 minutes. It's going to be a whistle-stop tour because there is so much to talk about, and I could talk about this for many hours on end and separate it up into many other topics, but I'll keep it brief and a whistle-stop tour for tonight. So I wanted to talk to you guys as a group of vocal coaches initially because I know that you guys have already got so much awareness of the mechanics of the orofacial complex and the voice and breathing and how everything is linked. So I know that I can talk a bit differently with you guys. And also within this field of oral dysfunction and orofacial myofunctional therapy, we could talk for an hour about teeth and dentition. We could talk about facial aesthetics. We could talk about swallowing. There are so many different areas within this. So for you guys, we're going to focus a little bit more on the mechanics and how that relates to the voice. So I'm sure a lot of you or most of you will have already seen this fantastic clip, but I just couldn't do this presentation without just giving it a bit of a nod. It's singing in the MRI. So we're going to look really briefly at the absolute intricacies and the wonderful interplay between all of the orofacial structures here and what goes on.
All'alba vincerò, vincerò, vincerò. All'alba vincerò, vincerò, vincerò. All'alba.
Okay, so we can see, I'm just going to skip forward to the next, we can see so much happening there in terms of movement of the jaw, movement of the tongue, movement of the lips, changes in depth and shape of the airway. The tongue is elevating, retracting, protracting. So it gives us a bit of a kind of an appreciation of the absolute complexity of these structures and how they need to work together. So I look at orofacial myofunctional disorders. Again, I said that sounds like an absolute mouthful, but breaking it down into its simplest form. Oro means mouth, facial means face, Myo means muscle, and function is obviously how these things function. And of course, I'm looking at how they become dysfunctional and what happens then during that. So the muscles of the mouth, the tongue, the jaw, and all of the head and neck basically help us with the functions of speaking and singing, breathing, swallowing, eating. So they are responsible for so much of what we do on a day-to-day basis. Okay. So sometimes for a lot of different reasons, not just tongue tie, but that's what we will focus on today a bit more. Then things can go wrong with these muscles, and some muscles don't work as well, and other muscles learn to compensate for them, and that creates imbalance. So we get this imbalance in facial muscles, and that is an orofacial myofunctional disorder. So examples of them can be tongue thrusting, mouth breathing, swallowing difficulties, and there are many more, as you'll see as we go through. So I'm just going to take you back to kind of childhood when orofacial myofunctional disorders might start, just to give you a little bit of a background and a context about these. So this lovely infographic comes from Dr. Zaghi, who is regarded as the gold standard, the kind of world leader in tongue tie, from his company, the Breathe Institute over in California. And I think it demonstrates how these things begin really, really well. So starting here with restricted tongue mobility. So that could be because the tongue is restricted because it is tied by a tongue tie, but there could be other reasons, such as, well, in infancy, dummy use, or different oral habits such as thumb sucking. There could be neurological reasons, many reasons. But when the tongue is restricted, the tongue develops a low resting posture. So basically that means that the tongue is sitting right down in the lower jaw, right down in the mandible, just resting like a carpet on the floor of the mouth, rather than sitting in the optimal position, which is lightly suctioned up into the palate, which we'll talk more about as we go on. When the tongue falls down into the mandible, we get mouth breathing. And that mouth breathing and the lack of contact with the tongue in the palate causes abnormal orofacial growth. So basically, guys, the tongue, even though it weighs just 30 grams, when it's lightly suctioned up into the palate most of the day and night, that helps those soft tissues respond to that and help to grow the face. And that structure, that palatal structure where the tongue sits, is the roof of the mouth, and the roof of the mouth is the same structure as the floor of the nose. And we want nasal breathing, so we get this cycle. So when abnormal facial growth starts, we have limited space for that tongue, which makes it harder. The dance floor for the tongue becomes smaller, so it becomes more restricted. And then we get dysfunctional orofacial myofunctional compensations, which we'll talk more about. So basically, guys, the main thing that this illustrates is that the tongue is the keystone for good oral function. Not the lips, not the jaws, all of these things come into it, but the tongue is the actual keystone for that. And us myofunctional therapists have a term we like to use called form follows function. And this demonstrates that really well, is that how those muscles are functioning determines how those structures form and how they grow and how they respond. So that's the little bit of background, but let's move on to you guys starting to identify how orofacial myofunctional disorders might look, maybe in your own clients, maybe in yourself, maybe in your family. So we're going to look at red flags and possible symptoms and impacts of orofacial myofunctional disorders. So the first one to talk about is mouth breathing. And with mouth breathing comes over breathing. We could do a whole presentation about this, and there are many people who have, and it's something we may well offer in the future as well. But for now, it's just something to be aware of. Another thing that we get in people with OMDs is TMJ disorder, so the temporomandibular joint becomes clicky, poppy, sore, creates headaches and tension patterns. And those tension patterns aren't just at the jaw, they're often in the neck, even into the shoulders and up into the head, because as we know, everything is connected. We can, of course, have difficulties with pronunciation. So a classic kind of symptom of a low-lying tongue or a tongue tie would be a lisp, which could be in the front of the mouth, or a th, or with air escaping out of the sides, like a. We can have issues with fluency, so actually making the words in a sentence flow. So like stammering, there isn't any research at the moment that links those two, but there soon will, believe me. And of course, voice difficulties, how the dysfunction within the mouth can affect the voice and how that's projected, which we'll definitely talk a little bit more about today. Then we've got malocclusion, so that's when the teeth aren't in alignment, or they could be crowded, and oral health issues. So I get a lot of patients with halitosis, dry mouth, gum disease, and other perioral issues. Again, as a whole other presentation there, but these are just things for you to be aware of. Chewing and swallowing dysfunction. So we get people who have difficulty swallowing or have an incorrect swallow, like a tongue thrust swallow that some of you may have heard of, or they're not chewing adequately and that's not giving them the correct support for their face. And with chewing and swallowing difficulties and dysfunction comes quite often digestive issues. So again, we have quite a lot of reflux. When we're not chewing and swallowing correctly, we may be swallowing extra air. We might not be processing our food properly. And you guys, as vocal coaches, know the impact on digestive issues and reflux on the voice for all those other reasons. And we probably won't have a lot of time to talk about that today. But again, there's probably another presentation there. And then lastly, but certainly not leastly, is sleep disordered breathing. Okay, so that is a massive umbrella term that incorporates basically snoring, sleep apnea, so pauses in breathing, unrestful sleep, waking in the night, and a whole host of other symptoms. And it's something that we must not underestimate when we're looking at health and wellness and even performance, because we know ourselves when we don't sleep well, we don't feel well, we don't perform our best, we don't feel on top of the world and ready to face the world. So that's something that's really important, and it's something that I, as a speech and language therapist, rarely ever asked about. And it would now always be one of the first things I would ever ask about with a client or a patient. So let's look a little bit more now about what oral posture should be. So our lips should be closed at rest, our tongue should be up, and we should be breathing nasally. But when we say the tongue up, so we would automatically assume that the tongue would be in contact with the palate. But what people tend not to know as much is how much of that tongue should be in contact with the palate. So here we're looking at a lovely infographic that demonstrates the tongue up in both scenarios. This tongue is by no means lying right down here on the floor of the mouth, nor is it protruding forwards and sitting between the teeth or between the lips, but only a small portion of that tongue is actually in contact with the roof of the mouth. And in fact, for correct oral rest posture and for correct breathing and oral function, we need all of the tongue, or certainly a really good proportion of that tongue, to be resting up in that palate. And the reasons for that are so crucial, and I hope that you'll find them so interesting. So basically, the tongue is a scaffolding for the airway. So it holds open that nasal passageway all night and provides that nasal patency. It provides structure to the back of the airway as well. And also, if you think of the tongue as a third leg in what is a tripod to hold closed the jaw, then the TMJ joints on either side are two legs of that tripod, and the tongue is the third, but really the most important leg that helps to maintain that stability within the face and take pressure off the jaw joints. So our lips, guys, shouldn't have to work to stay closed. It's the tongue lightly suctioned up into the palate effortlessly that creates that light vacuum that holds everything together. Lastly, and really importantly for you guys, as vocal coaches, the back of the tongue in contact with the back of the hard palate and even into the soft palate helps to tone the soft palate, the velum, and the oropharynx. So of course that's going to have a massive impact on voice and resonance. I'm going to pop a quick poll on now, which I hope works, because again, this is the first time I've done this, about how much of your tongue you feel sits on the roof of the mouth. I might actually dare as well to stop sharing and to come onto your screens, just me. Ooh, will that work? Hopefully you no longer see my presentation and you just see me. So we're going to do a little test now. Good, thank you. We're going to do a little test now to see how much of your tongue might rest on the roof of the mouth and to see what's going on there. So if I ask you to put your tongue out and press quite hard or have a little wiggle around with your finger on the mid to back of your tongue. So you're propriocepting it now and waking it up. And then you're going to just place it back into your mouth. And that bit that you touched, does it feel like that's touching the palate? And just have a think about how much of that tongue feels like it's adapted to that space. Another thing we can do is we can do tongue clicks, which look like this. And then we can see if we can actually hold that tongue click at the top. So that's called a lingual palatal suction. And during that, you should be able to feel that whole surface of the tongue in contact with the palate. So I'm going to go back to sharing now and hope that it goes back to the same place. Good, it did. Okay, so going back to the back of the tongue and the velum, guys, I think this is a really useful thing for you. So what we're seeing here is different mouths, and we're looking right into the back towards the velum, and we can see the uvula. We can certainly see the uvula here on class 1. So this is a Mallampati score, and it was originally designed for medics to look at how easy it might be to intubate a patient, but we use it in myofunctional therapy to look at how well the muscles at the back of the tongue are working and how well the soft palate and the velum are working. So this is something that I think you guys could really easily do, and it gives us a lot of information. So it actually, if we look at a class 1, which is an ideal scenario, we should be able to see the bottom of the uvula, and we should be able to see space either side. And if we go right to class 4, we're seeing none of that, and because there is very little tone there in that velum. So that gives straight away some information about how well that velum and soft palate are functioning in your client, and that's going to transfer on straight over to resonance. But of course, if we were looking at this from a more medical angle, we're so far more likely to see snoring in Mallampati class 3, 4 than we are in a class 1, because that airway space is bigger and everything is staying put and toned. And it does so, as you know now, guys, because of the back of the tongue and how it scaffolds that space. I'm going to pop off again now that I feel more confident to do it. Come back onto your screen and show you a couple of other good tricks that you can use to look at what the back of the tongue might be able to do. And that is to open wide as you can with really high jaw and say ka, 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 and see if you can keep that jaw stable. See if you need to compensate by going ka, 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 ka. What we want is to be able to keep the jaw really wide and for the tongue to work hard enough and to have enough range of motion at the back to elevate right up to make a clear ka, 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 ka. The same can be done with a laka, laka, laka. And so the front of the tongue is having to elevate, and then the back of the tongue is having to elevate. And is it able to do that without changing the jaw height? So that's another good one that you can try on yourself and or use with clients. I wanted to pop this slide in about jaw stability because it rings true for a lot of my patients and clients. So when we're talking about the tongue and what it can do and where it rests, and about the jaw maybe having to get involved to help the tongue to elevate or move to the side even. We need to be able to move our tongue side to side, laterally to chew, and lots of other oral functions. So the analogy I always use for patients is if you were going to make a jump into a lake and you wanted that jump to be really accurate and really long and you wanted to win the competition, would you rather jump from a stable jetty or a wobbly boat? And of course, they always say I'd rather jump from stable jetty. Why is that? Well, that's because you're going to get further reach, you're going to get further accuracy, you're going to feel more stable. So this relates directly to how the tongue can work independently of the jaw, not just the jaw though, the lips, the face, all of the muscles. So we need our tongue muscles to be working independently for maximum accuracy. And that's so important in speech and in singing. So we're going to look a little bit more and only briefly at the types and degrees of tongue tie. I will say it's really not possible to identify or diagnose a tongue tie just from how it looks. It's really got to be based on function as well as looking at symptoms and history. These again come from Dr. Zaghi, who I mentioned at the beginning, and his institute, and these are called tongue range of motion ratios. So as myofunctional therapists, we look at how wide the jaw will open and then how far the jaw can open with the tongue to what we call the spot, so the incisive papilla. And as you can see, this tongue reaches really nicely. This tongue not so much, less, and this tongue can barely lift at all. So they're opening their jaw really wide, but the tongue won't go. So that's how we look at the anterior motion of the tongue, what the front of the tongue can do. And in singing, that pertains more to the accuracy of certain consonant sounds. And then we also look at the tongue range of motion in lingual palatal suction. So that goes back to the picture where we want that whole tongue to be resting up in the palate. How much of the tongue can get up there and how much are we having to compensate basically to do that? So a grade 1 tongue tie can elevate most of or grade 1, not a tongue tie, grade 1, can elevate all of the tongue with a kind of effortlessly, and then as you can see, it becomes harder and harder the more tethered that tongue is. So basically, guys, a tongue tie is it's embryonic tissue that has been there since you were forming, your client was forming in utero, and it's deep within the body, and it's not going to be able to be taken away. Unless obviously we go for frenectomy, which we'll talk a little bit more about in a minute. But I think this is something you'll find a little bit more interesting about the tongue tie, is points of anchorage. Okay, so basically the string, the tightness, everybody has this frenulum. It's how our tongue is attached basically to our body. But it's how tight that is and where it attaches that indicate how it restricts the movement of the tongue. So if the lingual frenulum is here, where the red arrow is, you can see that the blade of the tongue is free, but the main body of the tongue is not free much to move at all, nor the base. So it would depend basically on that. So how this affects the voice? Well, massively. So if we think back to the amazing clip at the beginning that you will all have seen before, singing in the MRI, and how much the tongue needs to move up and back and forwards, and it needs to change its shape and size. And if we have restriction right here in the mid of the tongue, where the blue arrow is, how much harder that elevation is going to be. In fact, there may not even be enough elevation. So then, guys, basically what's going to happen, we're going to compensate. And you all know as vocal coaches how we're going to compensate. I'll let people put it in the chat box what you think we might be compensating. Oh no, we can't see any images. He's just come on. Hello, I'm back. Right. I'm going to go back to, did we have the images of jaw stability? No. Sorry, thanks, Gemma. Did we have the previous ones? After jaw stability, we lost you. Okay. Back to... Okay, so the pictures of the tongue tie. Please give me a yes if you can now see them. Yes, hooray, thank you. Okay. Right, I'm back. Okay. So as I was saying, you all heard me say that there are two different ways that we measure the tongue in relation to how far the jaw will open. So we measure its range of motion. And we're looking at it in two ways. We're looking at how far the front or the tip can elevate, and then how far the whole body and the back of the tongue can elevate. So these are the different ways that we do that. Gonna move a little bit more quickly on because you heard the audio part of it. I think you'll like this this diagram, which has the points of anchorage of where that tongue tie could be. So as I said, it's to do with how thick, how tight, and where that frenulum is actually placed, which again is why we really need to look at function and what else is going on rather than just looking at how it looks. So if the tongue tie is here at the red arrow, then you'll see the blade is free. We've got a bit of free tongue space, but the body and the posterior and the base of the tongue are so restricted. And then you missed this one as well, which is about how the tongue, if we're really restricted here at the blue, with the mid part of the tongue, how difficult it's going to be to then elevate the tongue. In particular, we're going to struggle with the vowels that really require elevation of the back of the tongue. So vowels like a E. And I had just begun to ask when I realized, how do you guys think, if you're really struggling to elevate the tongue, how do you guys think that you would then compensate for that? Or how would your clients compensate for not being able to get that really big lift in the tongue? Because whenever the tongue or whenever anything isn't working correctly, our bodies are going to try and compensate. Sandy said maybe look up to the ceiling and stick out the tongue. Yeah, so basically thrusting the tongue or trying to make some space here. Yeah. Another thing, something to do with the larynx that might go on that you guys might know about. Yeah. So laryngeal elevation. So we're going to try and, so all these muscles here are going to basically pull up on the larynx and heighten that. We're also going to try and compensate with the jaw by tightening the jaw. I'm going back. I'm having a few little technical issues here getting chat and things on. So lost that, but never mind. Hopefully my tech person will, oh yeah, I'm back to it. Higher larynx, yeah. So we're going to compensate. And these are things that as a vocal coach, as vocal coaches, you'll notice, and you'll probably notice them more than me because you're so tuned into the acoustics of those things. Okay. So we might even see also facial tension. We'll see signs of struggle somewhere and somehow, and they might be obvious. They might not be that obvious. There might be several compensations all going on at once. So we really need to be on the lookout for those. So put a poll on now that I'm going to ask you, how many of your clients do you suspect might be tongue-tied? This will be an interesting one. So next, guys, we haven't had much time at all to talk about body fascia, and how the tongue is actually linked with the diaphragm and the whole body through this deep frontal line of fascia. I'm hoping you can still see my screen. Yeah, I've got the wingman in the background. Yeah, you're telling me to keep the chat open and keep checking the chat. Okay, so the deep frontal line of fascia. So if you are familiar with it, you'll know a lot about that. People are saying, "Oh, this is fascinating. I love it." There's an amazing physician called Tony Myers who has a book called Anatomy Trains, which looks at the connection of this fabric and sinew that surrounds muscles, and fascia itself. Many people believe holds memory, and fascia can be tight throughout the body. I know there's a couple of people on here that are very fascia savvy, much more so than me, and that's why I feel slightly nervous talking about this. But basically, when we have a tongue tie and or other ties that we haven't had a chance to talk about today, possibly lip tie, cheek ties, when there is tightness within that very deep fascia in the body, there's generally other fascial tightness throughout the body, and that affects the movement of the whole body. And of course, you can see from this picture that this deep frontal line of fascia attaches right from the tongue to the lungs to the diaphragm. And these things are so crucial in singing as well. So how we are able to use our diaphragm obviously helps us with voice projection, breath support. So this is really, really, really interesting stuff. Just a little bit of context for me is that I realized a few years ago at the start of this journey for me that I was tongue-tied. And I'd probably compensated really well for it. Never had any TMJ, but I'd had neck and shoulder tension. I also used to get really fatigued, used to get a lot of issues with endurance when I was talking, being a speech therapist, telling stories and things. But I also have never been very bendy. I've always really struggled with touching my toes. And as I looked more into things, I realized that I did have diaphragmatic restriction and restriction around the lungs. And I know that it's all related to my body's fascia and how that all works. I have now had my tongue tie released once, and with some really good effects. And I'm more than happy to talk more about that later if anyone's interested. Anyway, moving on. So we know that there can be tongue ties and other oral dysfunction, but how can that be sorted? How can that be helped? So myofunctional therapy, which is basically what I do, and frenectomy, which is the process of actually going in and altering that frenulum and taking away that tension and tightness. Okay, so myofunctional therapy basically starts off always with assessment, and then assessment looks at function. We take measurements. We have a little ruler that looks at how far the jaw will open, and then how far it will move, its range of motion in those previous pictures to the incisive papilla and then the body of the tongue as well. And we look at how other facial muscles might compensate for the tongue or the pharynx or the lips not working well. And we look at the swallow, which again, we don't have time to talk about today, but it's all very fascinating in terms of how that works and how that helps everything. So then we'll usually be able to diagnose a tongue tie straight away if we see one, but sometimes we can't. Sometimes we need to get in there and do some therapy first and look at the impact once those tissues get moving and once the tongue knows where it needs to be more. So myofunctional therapy is generally long, starting with an intense phase where we are strengthening and raising awareness, and then moving on to repatterning all of those facial muscles so that they basically work in synchrony together for optimal airway support and for optimal postural support and all of those things. So at some point in the therapy, if the tongue is restrictive and we feel that it would be worth being released, we'll ask our patient to go and seek a frenectomy. And usually us myofunctional therapists prefer that to be a functional frenectomy, which would be a release provided by an airway savvy dentist who really understands the impact of the tongue on the airway and the impact of the tongue on the body fascia. And there are a couple of those in this country and a few in Europe now as well. And that's generally done with laser. So part of our job is to help our patients or clients to prepare for that, and then to help them to repattern after that as well. It's just done through exercises which use usually a few tools which are really fun and exciting. And I know that I've worked with quite a few singers who have found that their myofunctional exercises have been really useful for their singing in other ways, regardless from the orofacial myofunctional disorder, and who've stolen my ideas as well. But that's fine. I'm here to spread the word. So it's basically neuromuscular repatterning, so making the muscles work differently with the brain so that we never have to think about it again, so that everything works harmoniously. So, I've got an awful spelling mistake here. Sorry about that. Coaches, what to look and listen for. So, going back to the little diagram at the very beginning about the kind of red flags, those are the things you're going to immediately be looking out for anyway, and those would be present in anybody. But for you guys who've got so much more knowledge of the mechanics of it and the acoustics of it, I just wanted to go through a few things that might indicate for you that there is potentially oral restriction at play. So the first one is accessory muscles. So can you see the muscles of the neck moving and really getting involved and engaging when they shouldn't be? Because everything really should be relaxed and effortless. Can we see jaw height compensations? Is the jaw going up and down constantly in order to make different consonants and different vowel sounds? What's the articulatory transition like? Is it smooth or is it clunky? Again, with the jaw, or is there effort there on the face? Endurance is a really, really important one. It ties in really well with breath support, but also, what does your client, do they start off singing really well and then their voice or their articulation or their pitch changes and struggles towards the end because they're struggling with fatigue of muscles? Do they have their forward head posture? Do they really struggle for breath, or does their breathing change as they go on with singing? Then, of course, you're going to look at resonance and laryngeal strain, and we talked a little bit about how that can be affected by tongue tie. And a little bit, you can also begin to look at whether the floor of the mouth lifts, because I know that you understand the muscles and the digastric and all these kind of suprahyoid muscles and what you're looking for in there. So we really want there not to be that pulling and that tension, either looking from the inside or the outside. Just a few tools for you guys to share and to look at yourselves. So the first tool I'm obviously going to always recommend would be to have a myofunctional therapy or a breathing re-education assessment to look at those things. Tools that you can use to help to support the muscle tone of the face and the tongue generally. The Myo Munchie is a brilliant tool for all of those myofunctional goals. There's a tool called the iCoro, which is a little plastic device that you can now get on the NHS for reflux and snoring, which helps, goes behind the lips, and you pull it and you use it 3 times a day, and that helps to, again, it is neuromuscular reprogramming, but it helps to strengthen the pharyngeal and the esophageal muscles even because of those amazing connections between everything. There's Myofacial release, so looking at that fascia and where it's tight. And again, I know there is a couple of amazing myofascial and physio therapists in the voice world on the call tonight who would be definitely go-to people for that. But I think the biggest thing really is just self-awareness of knowing that, okay, maybe I am restricted, and how am I compensating, or how is my client compensating, and just starting to think about that, seeing if you can reduce those compensations yourself without, with the knowledge that you've got about your own body or about your patient's body. I've just listed a couple of useful books for you, so I'll pop them over on when the slides go out, and some references. I think this reference here would be so useful to you. I hope you'll all read it if you haven't read it already, which basically shows the impact of tongue tie on voice, and the outcomes of that were that basically 92% of the patients who had the tongue tie release and the myofunctional therapy saw significant changes in their voice in terms of endurance, in terms of pitch, in terms of fatigue, range, and breath support. So it's a really interesting piece. Some information about how to reach me, and then it's Q's and A's, which I'm aware that people have probably started to put a few things into the chat box already, but anyone at this point can feel free to try to unmute yourselves and ask a question. Sandy says, can you show the previous slide again, please? I'm not sure which slide that was, but I'll just try and whiz through them again. Okay. How do we unmute? I don't know. Andrew is the wingman. I'm going to ask Andrew to tell you that. I'm going to go through these previous slides. I'm so sorry. Go through these last slides for you, but like Andrew says, we'll get the slides sent out. I'm going to stop sharing again. Let's see if Andrew knows how to unmute. I think it's probably best then, instead, if we just put the questions in the chat box. I've got a question here about how much impact does the frenulum have for a voice user? Well, so talking about the lingual frenulum, which is the tongue connection, it's massive really, because the tension on there and the position of that frenulum affects the tongue in so many ways. So it affects how the tongue can elevate. So imagine this is the palate. It affects how the tongue can elevate, how it can lateralize, how it can retract, and how it can protrude. And it's going to do that in different measures every time, because every single tongue and every single frenulum is unique. And when it affects the tongue in that way, it's going to affect the surrounding structures as well. So it's going to affect the jaw height, especially if they're a person who's compensating by putting lots of pressure into the TMJ. As we talked about, it's going to affect the soft palate and the velum, which is going to affect the resonance. But it's just how long is a piece of string kind of scenario, and we have to look at, it has to be impact based. what the impact it's having on you is. So many people are walking around with tongue ties and they're coping fine, and might have one or two symptoms, but they're coping, and others who might be less restricted are having perhaps more impact. So it's really kind of individual case basis. I'm going back to the general chat. Please could you show the slide of the 4 tongue ties? Sure, I will. Oh, Louise is telling me how to unmute, but let me do the sharing of the 4 different types of tongue ties again. This one, I think the one you mean. So we're looking at this first slide is looking at the anterior range of motion, so what the tip or the front of the tongue, the blade, can do. And this is, of course, a completely free tongue. In an ideal world, we'd all be able to do this. We'd all be able to lift our tongue effortlessly with a nice wide jaw. And this is a grade 2, so the percentages are actually there, but I think for you guys that's probably not that relevant. And then grade 3, that tongue's barely able to move at all. And grade 4, the tip is completely anchored down. It just looks, you can see that heart-shaped bowing that kind of a lot of people associate with tongue ties before we start to think about anything else that's going on with the back of the tongue. So then here we've got the lingual palatal suction. So this one relates to the mid-body of the tongue and the posterior of the tongue and how that can elevate. So we can see the different shapes and sizes there as well. Let's stop sharing and come back to the chat. I have a student who's definitely tongue-tied and is in denial that it's affecting their voice. Can you recommend any exercises I could do which would help them with some self-diagnosis, self-awareness that there is an issue, even the resting tongue position you've just shared? So yeah, you could share that with them for sure. And then other ones that you could do, Sharon, would be can they actually elevate the back of their tongue enough with a wide jaw to make a K sound? Ka, 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 ka. And what you might find is that he or she can only go so wide, ka, 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 or they have to ka, 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 and they have to actually use the whole jaw, get the whole jaw involved in that, or that they just simply can't make the sound crispy enough and it'll sound like ha, 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 ha. So there's that one. And then the la-ka, la-ka, la-ka. Again, can the front and the back of the tongue make that kind of shuggy boat kind of motion without the jaw impacting as well? Without talking too much about voice and talking more about the oral hygiene, can the tongue actually be used to do its job, which is to clear away food from the gum sulcus and the teeth? And looking at the more medical impact on that client might be a good idea as well. So looking at that chart that I shared at the beginning, well, how do you sleep and how do you how does your jaw feel? Do you get headaches and all of those things? So looking at the rest of the impact, not just the impact on the voice. Could you demonstrate the 2 or 3 checks for tongue tie near the beginning of your presentation again? 2 to 3 checks. I'm not sure exactly which checks. Oh, I think you might mean the red flags. So I wonder if you mean, I'll just reshare that slide for a moment. So what the red flags are. So if you're having kind of one or more of these things, then it's really likely that there is definitely some tongue restriction there going on. Okay. I've dealt with clients with retracted tongue, but also overlifted tongue due to exaggerated training on high tongue dorsum, distorting speech. So looking for relaxation exercises. They've retracted the tongue, also overlifted due to exaggerated training on the high tongue dorsum. Okay, I see. So these are the kind of patients that I think would be perfect for myofascial release and helping them to release off some of that tension actually physically. So getting kind of inside the mouth and massaging. And then retracted tongue, overlift. Can they, perhaps that might be a client that you could use the bone prop with, so that they can practice different tongue heights with different jaw heights and how they relate to each other. Someone is asking, who would be the first port of call when advising a client singer about getting seen for tongue tie? I think you guys, as their vocal coaches, are probably the best people to start to have an inkling about what might be going on. And I know that there is a singer and vocal coach on here tonight, Gemma, who I've got to know quite well, who's actually going to be doing some singing, tongue and singing workshops and webinars with me. She said that it was her own vocal coach that identified it with her and said, I think you might be tongue-tied, based on information that they'd had, such as this kind of webinar. But then when you identify that, I think you need to be able to signpost them to some useful sites for them to kind of see for themselves. So signposting them to some of those articles that are referenced there, which will be sent in the slides, would be useful. Or you can also direct them to the BSMFT, so that's the British Society of Myofunctional Therapy, where there's information about tongue ties and myofunctional disorders. And on there, they could find their local provider of myofunctional therapy. I'm more than happy for them to reach out to me. And I do discovery calls, which are kind of a 30-minute call, just to ask a few more questions and to sort of begin to test the water about whether there may be potential restriction there. Okay, I had already just done them. Do I recommend any journals with the impact on tongue tie and dysphagia and dysphonia of voice? Well, the one that I put first on the list of references is the perfect one for dysphonia of voice, but I can add on there some for dysphagia as well, because as you know, guys, the palatoglossus muscle, which is right at the back of the tongue, is so linked to the palate, to the esophagus, to the pharynx and the tongue. So of course, when there's tongue tie, the oral transit through that phase is slower. So of course there are links, yes, with dysphagia as well. So I'll pop some of them on there. I think I've answered all of the questions, and I'm sorry, Louise, I ignored you about how to unmute, but I'll know that for next time. My wingman's telling me there might be more and more in Q&A. Who should we send our clients to after we suspect they are tongue-tied? So you can send them to me, by all means. So my website will be on there, on the slides, but you can also ask them to visit BSMFT, British Society of Myofunctional Therapy, or just to Google myofunctional therapy near me. There aren't a lot of practitioners in the country at the moment. So those practitioners are generally dental hygienists or speech and language therapists, 50-50 split at the moment. And we've all had this extra training that allows us to look at tongue function and oral function in that way. Okay. Any more questions? How are you? No, I think we're all done. So if anyone wants to ask me any questions, anything that they don't want to share on the screen or anything that comes up afterwards, please feel free to reach out via email. My email will be on the handouts, and I think you can either do it also through my website, which I think will be on the registration link. Thank you, everyone, so much for bearing with me because this is all very new to me. I'm really, really accustomed to Zoom and Skype, but not at all with this this new webinar thing. So it's been a bit of a test run. You've all been amazing. Andrew has popped my email on there in the chat. Gemma has popped the MDT, the MDT, the muscle tension dysphonia article in the chat as well. Thank you, Gemma. And thank you everyone for coming. Really hope it's been interesting. And like I say, reach out to me. Andrew said we'll get audio sorted next time. So reach out to me if you've got any further questions, and thanks again for coming. Bye, guys.